Good afternoon, and thank you for joining us today as we discuss what we learned and where do we go from here in COVID. We do have a couple housekeeping slides I want to get to real quickly. We do have a great panel today. You're going to recognize most of the names with Sue Bealey, Bobby Starkey, Audrey Howard, and Colleen Deegan. We want to make sure we have plenty of time for you to ask questions, but we do have a lot to get through. So just a couple housekeeping slides. With sound, if you are experiencing any issues, check the audio section in your dashboard. If you can't hear through your computer audio, you're also able to call in through the passcodes that are on your dashboard. The presentation is available in the handout section of the dashboard as well. Those are where your presentation slides are that you can download. At the end, we'd really appreciate your feedback. There will be a survey that launches immediately after the presentation, so please feel free to give us any feedback there. After the webinar, we will also be providing an archive of the recording so you can listen again, as well as a certificate of attendance. Those will all come to you via email. But like I said, we have a lot of information to get to, so I'm going to pass it over to Sue. Please feel free to also ask questions throughout the webinar. Like I said, we have a lot of content, so if we don't get to any of the questions, we'll follow up after, but please put those in the questions section of your dashboard as well. So without further delay, Sue, why don't you go ahead and kick things off?
Thank you, Lisa, and thank you for joining us today. Way back in December, we met with you all for a look back at all that we had experienced with regard to COVID-19 from a coding and CDI perspective. At that time, we talked about the evolution of coding for COVID-19, the impact of it on publicly reported data, and we also, did a little focus on analysis and auditing of COVID-19 data. So here we are today, a little more than 6 months into the new year, and we've just passed the halfway point. We thought it would be a good time to get together and talk about what we've learned since then and take a look at where we might be going with regard to COVID. So let's start by talking and taking a quick look at the agenda today. Bobby's going to start by talking about COVID-19 therapeutic and diagnostic codes and payment updates. Audrey will spend a little bit of time talking about the fiscal year 2022 inpatient prospective payment system proposed rule for quality reporting as it pertains to COVID-19. And we'll also talk about the new ICD-10-CM code for Sequela of COVID-19 that was recently released. And Colleen will round out the presentation today by talking about COVID-19 encounters in the outpatient setting, as well as talking about the coding of adverse effects of COVID-19 vaccines. I think we'll have a few minutes at the end for questions, but as Lisa said, if we don't, we'll respond to any questions we might receive offline. So I wanted to just briefly talk about the public health emergency. So the public health emergency was renewed for another 90 days, beginning on April 21st of this year, and it extends through July 19th, 2021, which is next week. The public health emergency can only be extended for 90 days at a time. However, CMS has unofficially stated that the public health emergency is likely to last until the end of the 2021. I wanted to just briefly mention that in the proposed IPPS rule for fiscal year 2022, which Audrey did mention some things from that rule, and we are going to have the final rule coming out in August sometime. There is a proposal to continue the new COVID-19 treatment add-on payments, known as NCTAP for short. This would remain available for inpatient cases involving eligible treatments for COVID-19 for the remainder of the fiscal year, during which the public health emergency ends. So the purpose of this proposal is to avoid hospitals experiencing any financial disincentives to provide new COVID-19 treatments to patients. And if you've been following COVID-19, treatments and, treatments that have been successful and those that might not be so successful or deemed unsuccessful, we've kind of seen that thread throughout the pandemic. So this means that, existing treatments or new treatments that may arrive, hospitals will, be not disincentivized to provide those treatments. And what this is saying is that if the public health emergency, let's say it ends in April 2023, the add-on payment for new COVID-19 treatments will continue to the end of that fiscal year, the end of the fiscal year which the public health emergency ends. And in this particular scenario, that would be September 30th, 2023. So on screen, you just see a snapshot that I took out of the final register that talks about this proposed rule. And then on my next slide, and Bobby referred to it a bit, we, I wanted to mention, there's been this barrage of new codes, CPT, HCPCS, ICD-10 CM, ICD-10 PCS, throughout this public health emergency, starting, back, March, April of 2021, so 2020. So, what we did, and this is just a snapshot, Bobby actually maintained a timeline of all of these new codes and effective dates for us. It's actually, the thing is 22 pages long now. So this was just a snapshot, and we were, if I would have done this in order, we would have rolled into Bobby's presentation and she would have started to talk about some of those monoclonal antibodies, which, are in our timeline, and perhaps you all have maintained a timeline. But I think that's a very important thing to have in place, because as you go back to audit or you get denials, you can kind of see, where were we at that point in time with regard to code and effective date and things like that.
Okay, thank you, Lisa. As Sue said, I'm going to talk a little bit about the code and payment updates for therapeutic and diagnostic services in regards to COVID. There we go. So the first thing I wanted to talk about was monoclonal antibody treatments. And on April 16th of 2021, the FDA revoked the EUA, or Emergency Use Authorization, for bamlanivimab when it was being administered alone. And this was due to a sustained increase in COVID-19 variants in the United States, where they have become resistant to that product when used by itself. There is still an EUA, Emergency Use Authorization, in place for bamlanivimab when it is administered together with atezolizumab. And if I butcher any of these, I apologize. In addition, for monoclonal antibodies, on May 26th of 2021, the FDA released a new EUA, and CMS released a new HCPCS code for sotrovimab monoclonal antibody treatment. On June 3rd, 2021, the FDA revised the EUA for casirivimab when it's given with imdevimab, so that the new administration dosage of 1,200 milligrams could be reported. So prior, we had a HCPCS code for 2,400 milligrams. They just created a new HCPCS code for 1,200 milligrams. And in addition, they revised 2 of our administration HCPCS codes to include subcutaneous injections so that they could be administered via that route. And just of note, monoclonal antibodies do need a physician order for those services. As far as payments for monoclonal antibody administration, prior to May 6, 2021, the payment for monoclonal antibody administrations for Medicare was $310 per administration. After May 6th, it was increased to $450 per administration. And then for those patients who received their administration in their home or residence, the rate was increased to $750 per administration. Then, moving on to vaccine administrations, on March 15th, 2021, CMS updated the payment rate for vaccines, COVID vaccines, to $40 per administration for each dose in the series. And then also April 13th, 2021, the FDA did put a pause on the use of the Johnson & Johnson vaccine. It was a 10-day pause. On April 23rd, 2021, the FDA and the CDC lifted that pause, and that was due to potential for adverse effects of those vaccines. And then as far as vaccines go, you do not need a physician order to perform vaccination services for COVID. And then most recently, effective June 8th, 2021, CMS created a new HCPCS Level 2 code, M0201, for an additional $35 payment in addition to that $40 payment per dose in the series that we talked about on the prior slide, for administering the COVID vaccine to certain Medicare patients in their homes. And this was, the Biden administration had put this into place because people weren't able to get out to get their vaccination. So incentive was for providers to go into their homes. This M0201 code would only be reported once per home per date of service. However, if a provider would go into a home and administer vaccines to 3 people in that home, the M0201 would still be reported once, but the dose and product-specific COVID-19 administration codes would still be reported 3 times, one for each of those patients that received the service. And then just a slide to show CMS's criteria for home. So those code services that get an additional payment for being provided in the home, this is the criteria from CMS. If you notice the bottom bullet on the right-hand side, patients who are in assisted living facilities that participate in the CDC's Pharmacy Partnership for Long-Term Care program do not meet the criteria for home, but those patients who live in an assisted living unit that do not, the assisted living facility does not participate in that program, they do meet the criteria for home. And then this is a slide Sue would have mentioned about, we kept the timeline for COVID to keep track of when new codes got added, new EUAs were approved, when they were rescinded or revoked. And this is just a snippet of that timeline. This is for U0003 and U0004 HCPCS codes, which were created to report high throughput lab testing for COVID tests. And they were made effective April 14th, 2020. Well, we're going to talk about this now because on January 1st, 2021, there was an add-on payment that became effective, and the payment for these 2 codes was reduced from $100 per test to $75 per test. At that same time, CMS created a new code, U0005, that would be used with the 2 high throughput testing codes as an add-on code and would create an add-on payment for $25. So the high throughput testing was testing that uses technology that can process more than 200 specimens a day. But back in October, when CMS amended the ruling to change this payment rate, the tests were, there was a lag in the test getting completed. So CMS created this U code and the add-on payment to help get the test turned around in a more rapid fashion. So they created criteria that had to be done in order to report this, or met in order to report this U005 code for the additional payment. So the 2 criteria that needed to be met was, 1, the high throughput test needed to be completed in 2 calendar days of less from the date of the specimen collection. And, not or, but and, the majority of their COVID-19 high throughput technology tests needed to be performed in the previous calendar month within 2 calendar days or less for all of their patients, not just their Medicare patients. So in order to meet these 2 criteria, hospitals had to really think about how they were going to operationalize this. In addition to that, if you would happen to get audited for these services, you need to make sure that you have documentation to support you've met these 2 requirements. I also wanted to mention here that it's 2 calendar days, not 48 hours, so there is a difference there. And then I wanted to talk a little bit about the CS modifier, even though nothing new has occurred this year in regards to regulatory or guidance. A little history on the CS modifier. Back on March 13, 2020, the Department of Health and Human Services authorized some waivers under Section 1135 of the Social Security Act. And they made these waivers retroactive to March 1st, 2020. The waivers were put in place to prevent gaps in access to care for patients affected by the public health emergency. The Families First Coronavirus Response Act was one of these waivers that was put in place to waive cost sharing under Medicare Part B for Medicare patients who receive COVID-19 testing services. Cost sharing is the co-payment and deductible amount that patients have to pay out of their pocket. So the CS modifier was effective before April 23rd, 2020. It was used for the Gulf oil spill, but they reutilized it as of April 23rd, 2020 for COVID-19 PHE. And after it became effective, there was really vague guidance as far as what codes it should be appended to, how it should be used. And so we saw a lot of inconsistencies in the reporting. On August 27, 2020, CMS issued an article, Medlearn Matters article, regarding what codes it would be appropriate for the CS modifier to be appended. And they gave 2 lists in that article. One list was for services that were reimbursed under OPPS. The other list was for services that would be reimbursed under the physician fee schedule. On the right-hand side, this list is the entire OPPS list. So as you can see, most of these are E&M services, a few telehealth services. There are no diagnostic services on this list. I don't have the physician fee schedule list here. It was a little bit bigger, but again, no diagnostic tests on either of these lists. So if you're applying the CS modifier to diagnostic services such as chest x-rays, your COVID testing, influenza or strep testing, urinalysis, those would be inappropriate. And in that Medlearn article, CMS states that if they're not on the list and CS modifier is used with them, they're going to return the claim. So that's the reason we're mentioning that on this presentation is if you're seeing an increase in your outpatient denials, this may be the reason. Also, the MACs didn't get their edits in place until October of 2020. So we had no safety net as far as when we reported these CS modifiers. There is one code on the OPPS list that is not an E&M service or a telehealth service, and that's the C9803, which is the swab collection of a specimen for COVID testing. That code would be appropriate with the CS modifier. And then you also have to think about if you didn't report the CS modifier on your E&M services or your telehealth services, those patients more than likely paid a copayment or a deductible on those claims. So there may be a potential for some rebilling there as well. And then the final thing I wanted to talk about, the CMS frequently asked questions for COVID was updated on June 4th, 2021. And someone had questioned, will there be quality metrics associated with COVID-19 vaccines? CMS's response is that they are partnering with the CDC to develop quality measures for both patient and personnel vaccinations, and they would use them in programs such as nursing homes and dialysis facilities. So on that note, I'm going to turn it over to Audrey to talk about quality impact with COVID.
Thank you so much. And let me see if I can get my mouse to work, and hopefully everybody can hear me, but I have unmuted myself.
Sound good, Audrey.
Thank you so much. And it kind of did jump forward. Yeah, that's what I was afraid of. I had to take a lesson from Sue not to let the slides go crazy on me here. But I am going to start talking about the proposed changes for fiscal year 2022 and as it relates to quality and COVID-19. For the hospital inpatient quality reporting program, hospitals are required to report data on measures selected by CMS for a fiscal year in order to receive the full annual percentage increase that would apply otherwise to the standardized amount applicable to discharges occurring in that fiscal year. In fiscal year 2022, CMS is proposing to adopt 5 new measures. The one measure that is COVID-19 related is the COVID-19 vaccination coverage among healthcare personnel measure, beginning with a shortened reporting period from October 1st, 2021 through December 31st, 2021. And then affecting calendar year 2021 reporting period and then fiscal year 2023 payment determination, and with quarterly reporting beginning with the fiscal year 2024 payment determination and for subsequent years. I just hit the wrong button there, so now let's go forward and not backwards. There we go. CMS often asks for public comments on certain topics. For fiscal year 2022, one such topic is the development of a mortality measure for patients admitted with COVID-19. It will be interesting to read the comments submitted and see what CMS decides to do with the creation of a measure in the IQR program. CMS notes that there is a significant impact from the public health emergency. In March 2020, CMS allowed hospitals not to report the first quarter 2020 hospital-acquired infections data. Without this exemption, a hospital would receive a 1% payment reduction on every IPPS patient for failure to report. Hospitals could still report HAI data, but they were not required to do so. Then CMS issued a second remittance extending the exemption to second quarter 2020. Another CMS remittance in September of 2020 noted hospital-acquired infections data from first and second quarter 2020 would not be used to calculate the fiscal year 2021 or fiscal year 2022 payment, even if reported. CMS normally utilizes 2 years of hospital-reported HAI data to adjust payment via hospital-acquired condition reduction program and the hospital value-based purchasing programs. This change results in utilizing only 6 quarters of data instead of 8. The rationale for this change was due to varied rates amongst hospitals and varied peak hospitalizations across the country. Oh, where did my little mouse go? There we go. Now, CMS did not extend their exemption from reporting HAI data for third and fourth quarter of 2020 or first quarter of 2021. However, CMS will be publishing the data with an asterisk explaining the variation due to the public health emergency. CMS will continue to assess the impact of HAI data and adjust reporting periods. In addition, CMS will still give hospitals their HAI reports to assess and monitor their performance. See if that works. There we go. Whoops, and I hit it twice. Okay. The payment adjustment for fiscal year 2022 is not really impacted by COVID-19 since the measurement periods are prior to the public health emergency, with the exception being the hospital-acquired infections we just discussed on the previous slide. However, CMS is concerned that subsequent data will be affected by COVID-19. For fiscal year 2023, CMS is shortening measurement periods to end December 31st, 2019, which would be an 18-month period, so COVID-19 will not influence performance. It is unclear how measurement periods will be adjusted going forward, but detailed analysis and recommendations are found in the proposed rule. CMS is proposing to remove any claim with COVID-19 as a principal or secondary diagnosis from the quality programs due to higher complication rates, readmission rates, and mortality rates. These are the penalty programs where the hospital will get fines and rewards based on their performance. Overall, CMS is proposing to modify penalties and/or incentive payments for most of the quality programs. Some programs will have modified penalties or suppressed measures. Hospitals will still receive their performance results even if not utilized to calculate performance. And results will still be posted on Care Compare with an asterisk and comment about the effects of the public health emergency on quality. This slide is showing what CMS thinks what the payment adjustment will be for the health, the HAC reduction program and the hospital readmission reduction program. Readmission penalties are based on a benchmark against a national standard. In the HAC reduction program, a facility will only get a penalty in the bottom 25%. At this point, we don't know what the 25% bottom will be until we get a year's worth of data. In the HAC reduction program, a facility in the bottom quartile is penalized 1% on every single patient, every IPPS discharge for the entire year. CMS is proposing to change reporting period or the measurement period by taking out the first 6 months. 24 months is standard, but they are proposing to shorten it by 8 to 18 months due to the COVID-19 pandemic. Third and fourth quarter will not be used to calculate fiscal year 2022 payment adjust. It is unclear how fiscal year 2023 will be adjusted, as it would reduce performance to only 12 months. Did the slide change? Forgive me. Whoops. I am losing control here. I see it turning. There we go.
Yeah, and if you want to, since Colleen is sharing her screen, if we just want to go with, if you just want to ask her to say, and just say next slide, we can do it that way as well.
Okay, hold on. My, it does keep just moving.
I can see it jumping.
Yeah, and I need to get it back to the prior.
Let me try, Audrey.
Yeah,
you're looking
slide
for
27.
This slide? Slide 27.
No, the slide right before it.
Before 27?
No,
right
27.
Here?
Is that
okay.
27?
There's 27. Yep, this is 27. That's 26.
Okay. So this is slide 27. I've got something right over here that's not letting me see what slide number it is.
This is 26 that's up on the screen right now. This is
okay,
27.
I want the next one, please. Please, the next one, 27. Okay.
Okay.
There, that's the one I'm looking for. So in regards to the hospital value-based purchasing program, this slide is showing how the current program is set up. There are 4 domains that are equally weighted from which a total performance score is calculated. The domains include safety, patient satisfaction, outcomes on 5 hospital-acquired infections, and efficiency. So the next slide, please. So slide 28 is going into the value-based incentive payments that are made in a fiscal year to hospitals based on their performance on measures established for a performance period for such fiscal year. For fiscal year 2022, CMS is proposing to establish a measure suppression policy for the duration of the public health emergency for COVID-19. Suppress the hospital consumer assessment of healthcare providers and systems, Medicare spending per beneficiary, and 5 healthcare associated infection measures for fiscal year 2022 program year. Also suppress the hospital 30-day all-cause risk standardization mortality rate following pneumonia hospitalization measure for the fiscal year 2023 program year. Next slide, please. CMS is proposing to revise the scoring and payment methodology for the fiscal year 2022 program year such that hospitals' total performance scores will not include calculations based on these measures. CMS believes that awarding a total performance score to any hospital based off the remaining measures that are not suppressed would not result in a fair national comparison, and as a result are proposing not to award a total performance score to any hospital for the fiscal year 2022 program year. Instead, CMS is proposing to award each hospital a payment incentive multiplier that results in a value-based incentive payment that is equal to the amount withheld for the fiscal year. CMS is proposing to remove the CMS Patient Safety and Adverse Events Composite, or PSI 90, measure beginning with fiscal year 2023 because the costs associated with the measure outweigh the benefit of its use in the program. CMS is also proposing to update the baseline periods for certain measures affected by the extraordinary circumstances exception granted in response to the COVID-19 public health emergency. Next slide, please. In regards to the hospital readmissions reduction program, this slide is showing how the current program is set up. The program requires a reduction into a hospital's base operating DRG payment to account for the excess readmissions of selected applicable conditions. The reduction is based on a hospital's risk adjusted readmissions rate during a 3-year period for the 6 diagnoses and procedures that are listed here on the left-hand side. Next slide, please. CMS is proposing to make some changes to policies for the hospital readmissions reduction program. One proposal includes suppressing the hospital 30-day all-cause risk standardization readmission rate following pneumonia hospitalization measure for the fiscal year 2023 program year. Analysis of the CMS 30-day pneumonia readmission measure claims data showed that a higher proportion of patients had a secondary diagnosis of COVID-19 than other readmission measures, and that these patients have a higher risk of mortality than the remainder of the admissions in the pneumonia measure cohort. Next slide, please. Another proposal in the hospital readmissions reduction program includes modifying the remaining 5 condition-specific readmission measures to exclude COVID-19 diagnosed patients from the measure denominators, beginning with the fiscal year 2023 program year. And next slide, please. This slide is providing additional information about the changes to the hospital's readmissions reduction program, essentially saying CMS will not for a facility in the 30-day pneumonia readmission measure. Once again, that is all the information that was related to the proposed changes. We will find out in a few weeks when the final rule is released what CMS has decided to finalize. And for your information, we will expand on the proposed changes in another presentation during the Client Experience Summit next week. So as we go to the next slide, we're going to shift gears a little bit and talk a little bit about the COVID-19 sequelae. And just to let you know, this information is for both the inpatient, go ahead to the next slide, for the information is for both inpatient and outpatient encounters. I'm probably going to kind of hit the angle from the inpatient side, and then when Colleen picks up, she's going to talk about this from an outpatient standpoint. Just to let you know, a new code is created that will become effective October 1st, and that is U09.9. It will be titled Post-COVID-19 Condition, Unspecified. You'll see on this slide what they are including or some notes that are included under there. They are saying that this code enables the establishment of a link with COVID-19. They are saying that this is the post-acute sequelae of COVID-19. And then they have some coding directives in here about code first, the specific condition related to COVID-19 if known. So in other words, this U09.9 will be a secondary diagnosis. Your first listed or your principal diagnosis would be the specific condition that's being related to the COVID-19. So as we go to the next slide, I do want to reiterate that this is a new code that will become effective on October 1st that will be specific for the post-COVID-19 condition. We've had some advice already regarding COVID-19 and the coding of the sequelae of it. That's been printed in Coding Clinic. It was first put in the frequently asked questions that's on the AHIMA and the Coding Clinic Advisor website. So what was used prior for the sequela was a code B94.8. So this code, the U09.9, will be specifically for sequela of the COVID-19. So it will have its own code. It is interesting the fact that they are putting it back in the Chapter 22, the U category range. I do know that the World Health Organization did first release the code, and then so the NCHS or the United States version will be adopting the same code. So it'll be going back in there. So from a coding standpoint, when you do have a patient that's admitted or seen in the encounter for a COVID-19 related condition, and I'm already establishing the link there between the COVID-19 and the related condition, the first question that you really have to ask yourself is, does the documentation support the condition is an acute manifestation of a current COVID-19 infection? And if that is the case, then your principal diagnosis or your first listed code would be the COVID-19 code U07.1, followed by any of the acute manifestations. However, if that COVID-19 is not an active or a current infection, then instead you would be listing your presenting condition as the first listed or principal diagnosis, and that could be like some embolisms, pneumothorax, that multi-system inflammatory condition. That would be listed first, and then you would follow it by the COVID-19 sequelae code or the post-COVID-19 code, which right now, B94.8 or effective October 1st, U09.9. So we go to the next slide. I'm going to say that not every, I'm anticipating what the next slide is. I think I know what it is, but I don't want to get ahead of myself. There we go. Not all the time is the documentation going to be as clear as day regarding, is that COVID-19 a current infection, or is it no longer active? It's a past, the virus is no longer active or current. I mean, so if the documentation is not clear for you to be deciding which path you want to go down on that. You're going to have to query for clarification. And this slide is just showing a good example of how to query the provider. So, you know, it is saying that the patient is, you know, has a condition, but, you know, we want to know what is the current status of the COVID-19 infection. Is the, for example, pneumothorax due to current or active COVID-19 infection, that the COVID-19 infection has not yet resolved? Or is that pneumothorax, that's my example right now, is due to a previous COVID-19 infection, and that COVID-19 is no longer an active infection? Other, you know, have the provider specify any other, or is it just clinically unable to determine? And so those are some good options to be able to provide to the provider. And I believe at this point I'm turning it over to Colleen, and she's going to continue on the same as I stated from an outpatient angle.
Yep. Audrey, you can hear me okay, right?
Absolutely, loud and clear.
Okay, so excellent. So thank you, Audrey, Bobby, Sue. My name's Colleen Deegan. I am an outpatient consultant for 3M. I focus on documentation integrity, coding and reporting in the hospital outpatient and professional service settings. So as Audrey shared just prior, there are many patients with COVID-19 conditions related to that, to having an acute infection of COVID-19 when the infection is no longer active. So in addition to the hospital admissions or hospital readmissions for these complications, we are seeing these patients in the hospital outpatient setting. So COVID-19 can attack the body in a wide range of ways, causing damage to the lungs, the heart, the nervous system, kidneys, and so on. We're also seeing mental health problems arise from grief and loss, from unresolved pain and fatigue, or from just post-traumatic stress disorder after long ICU visits. So there's a need for continuing care, and even, you know, in some cases, readmission for these lingering problems. They can affect patients with comorbidities, and not just those that were severely ill from COVID-19, but really changes or post-COVID conditions in all types of patients. So again, a wide variety of health effects can persist long after the illness has resolved. And we don't know at this point. It's unknown how long these multi-organ systems might be affected, how long it would last, and whether or not the effects can even be considered chronic health conditions down the road. You know, just when we talk about the outpatient settings, where are we seeing these patients coming in for post-COVID-19 sequelae? I've listed a few of them here: emergency departments, certainly, urgent care centers, or hospital outpatient clinics, such as physical therapy clinics or respiratory therapy clinics, behavioral health clinics. We have seen organizations opening up post-COVID clinics or recovery programs to support these patients with symptoms that occur for weeks and months after the resolution of the acute COVID-19 illness. Some are referring to them as the COVID long haulers. So from a coding and reporting perspective, I think it's important to just, you know, again, our wide range of audience here, from CDI to coding professionals and many outside of coding and CDI, but speaking particularly, as Audrey stated, this is in the official coding guidelines, just the term Sequela and what the definition of that. So it appears in Section B, which is under the general coding guidelines, and it defines a sequela as a residual effect or condition produced after the acute phase of an illness or injury has terminated. States there's no time limit on when a sequela code can be utilized. The residual may be apparent early. It could be months or even years later that the residual appears. As Audrey stated, coding of sequela generally requires 2 codes sequenced, and there's a mandatory, if you think of the old school ways of slanted brackets, I've been around a while, you do see mandatory sequencing or code first type notices in the coding direction. So we list first the condition or nature of the sequela that's being reported, and then, of course, as Audrey mentioned, either that B94.8 or that new code starting in October would be sequenced as a secondary diagnosis. Very important to note that the code for the acute phase of the illness or injury that led to the sequela would never be used with the late effect code. So we should never see the U07 reported with one of these Sequela codes, the B94.8 or the U code coming into the future. So what happens when COVID-19 symptoms don't go away? In some who recover, lingering health problems can remain for months. While it's clear that people with certain risk factors like hypertension or smoking or obesity, diabetes, are more likely to have a serious bout of a COVID-19 illness, there is not a clear link between the risk factors and long-term problems. And per the CDC, the Center for Disease Control and Prevention, clinicians and researchers are still understanding post-COVID conditions. The most common ones being reported today: dyspnea, increased respiratory effort, fatigue, ongoing problems related to loss of taste or smell, cognitive impairment, chest pain, headaches, palpitations, tachycardia, insomnia, lightheadedness, just general inability or impairment of daily function and mobility. Again, we see patients experiencing the acute and these post-acute effects of COVID coming from social isolation as well, resulting from the pandemic measures. So we see those mood disorders or mental health relationships around depression, anxiety, and mood changes around some of the isolation effects that we saw. So we're seeing a wide range of patients. And we're going to take a look at a couple examples that do show up in coding clinic. To Audrey's point, there's sometimes very in-the-box examples. So we do encourage you, of course, if the documentation is not clear or it's inconsistent, to query your provider to make sure that the conditions being treated are either part of an acute phase of COVID-19 or a residual. So the first example is a patient with Guillain-Barré syndrome following COVID-19 and clearly stating the patient no longer has COVID-19. So this is a pretty when I think about the CDC and the top late effects they're tracking, this is definitely one of them. So the direction, again, that we would assign the G61.0 as the primary or first listed code. That's what we refer to it as in the outpatient setting. In the inpatient setting, of course, it's referred to as the principal diagnosis. In the outpatient setting, we often refer to it, and if you look in the guidelines, it's either called the primary diagnosis or the code listed first. And that would, again, be followed by the B94.8, which is a sequela of other specified infectious and parasitic diseases. Again, to Audrey's point, we do have a late add-on, actually, for 10/1/21, this U09.9. So that will replace B94.8 for COVID-19 sequelae. It's not, B94.8 is not going away, but again, a very unique code in that U range for sequela related to COVID-19 infection. The second example there is a patient who complained of recurrent lightheadedness. This is a very common, a lot of reading that I do around just this range of conditions. I'm lightheaded, brain fog, fainting, rapid increase in heartbeat when standing up from a reclining position. Due to a workup, a patient was diagnosed with what's called postural orthostatic tachycardic syndrome, or POTS syndrome. From a prior COVID-19 infection. We would have that same direction to assign the I49.8, other specified cardiac arrhythmias, as the primary or code listed first, followed by the sequela code. One example that I did want to talk to you about, because this is, again, some of what we struggle with is the way things are documented. And again, our job as coding and CDI professionals is to make sure that integrity of what's documented is told with the code set. So this is a patient who presents to the emergency department with symptoms such as generalized weakness and lack of appetite, and the provider simply documents the post-COVID-19 syndrome. So in this case, the direction we have from coding clinic is not to assign this as a sequelae, but actually to assign the R53.1 for the weakness and the R63.0 for the lack of appetite, followed by a Z code for a personal history of COVID-19, which is Z86.16. So clearly stating in coding clinic, unless the provider specifically documents that the symptoms are a result of COVID-19, that we want to report the symptoms followed by a personal history of COVID-19 code. So per the AHA FAQs as well as coding clinic, the term post-COVID-19 syndrome indicates what they refer to as temporality, but not that the current symptoms or clinical conditions being reported are an actual true residual effect or a sequela of COVID-19. So moving on to the last topic that we're going to talk about today, which are the vaccine reactions. A few facts from the CDC about vaccines, or in general, the COVID-19 vaccines. So these are coming right from the CDC's website. COVID-19 vaccines are safe and effective. Millions of people in the U.S. have received COVID-19 vaccines. CDC is currently recommending that everyone over the age of 12 and older receive the vaccination. There are some side effects being reported. We're going to talk about those here in a minute. Most side effects that affect your ability to do daily activities go away in a few days. There are some serious adverse events being reported. They are rare, but they are occurring. So we're going to talk about a few of those here on the next coming slides. So the CDC is monitoring what they're calling serious adverse effects related to COVID-19. And the four really sort of buckets that they're looking at is a patient experiencing anaphylaxis following COVID-19 vaccination, something referred to as TTS or thrombosis and thrombocytopenia syndrome, particularly related to the Johnson & Johnson vaccination, seeing patients with myocarditis and pericarditis as a result of vaccine reactions, and actually reports of death, finally, that last one there, reports of death following a vaccination for COVID-19. I want to read a few stats to you. This comes from the CDC website, and I actually was looking at this the other day, so it was actually last updated on July 6th. When I looked again this morning, it hadn't been updated yesterday. So the facts that I'm going to report to you here quickly are current as of yesterday. And what they state regarding anaphylaxis is there are 2 to 5 persons per 1 million that are experiencing anaphylaxis following the COVID-19 vaccination. Related to the TTS, there's been approximately 12.6 million doses of the Johnson & Johnson vaccine in the U.S., and there have been 38 confirmed cases of TTS following that specific vaccination, the Johnson & Johnson vaccine. There have been 2 cases of TTS following the Moderna reported, but that's over 318 million doses being reported. So at this point, the CDC, based on that information, is not seeing an increased risk of TTS following the Moderna vaccination. The third one there, myocarditis and pericarditis, there's been to date as of yesterday 1,047 reports to the CDC. They have an adverse event reporting system. So there's been 1,047 reported, and of that 1,047, they've confirmed 633 cases of myocarditis or pericarditis following vaccination for COVID-19. The last one there, the reports of death. The FDA does require healthcare providers to report any death following a COVID-19 vaccine. They have to report it to the CDC's adverse events reporting system called VA. It's called VAERS, VARES. There have been 330 million doses of vaccines in the United States from December 14th of 2020 through July 12th of 2021. And of those 334 million cases, again, the FDA requires the reporting of death. There's been 6,079 reported deaths. So the reporting of an adverse event, including death, does not necessarily mean that a vaccine has caused the health problem. And a review of available clinical information, including death certificates, autopsies, and medical records, the CDC has not established a causal link between the COVID-19s and death. However, recent reports indicate that there is a plausible causal relationship between the Johnson & Johnson vaccine and TTS, that thrombosis and thrombocytopenia syndrome, which is a rare and serious adverse event. It's a blood clots in a patient with low platelets, and that has caused some of the deaths. So they're still working through the relationship there, but again, knowing that they are required to report these deaths. So I wanted to put that in context to again, what are some of the things that we're seeing? So I'm going to give you a few examples here. Again, we're seeing anaphylaxis, we're seeing allergies, and we're seeing adverse effects. So this first one here is a patient really just an allergic reaction to the vaccine. So most of these patients are going to be likely fairly acute following the vaccine. So the ED would be, emergency department would be a common place to see these patients present. So you have a patient presenting to the ED with complaints of throat tingling and chest tightness following the administration of COVID-19 vaccine. and the provider documented an allergic reaction to the vaccine. So the coding clinic would instruct us to assign the T78.49XA, other allergy, that A again for initial encounter as the code we list first, followed by the symptoms the patient was presenting with, the chest pain, as well as the tingling of the throat, which is another specified signs and symptoms in the circulatory and respiratory system. The next one is not case specific, but it was important. I did see this in coding clinic, and the question was asked around normal or expected side effects of COVID-19 vaccination, and should they be coded for patients either seeking medical care or patients that reside in a nursing home or are currently hospitalized and receive the COVID vaccine. So if the side effects meet reporting requirements, if they're normal or expected, should they be reported? And the response from coding clinic was yes, that it would be appropriate to report a code or codes for side effects when the patient requires additional treatment or medical care, such as monitoring or treatment for the side effects. The other two that I have here to wrap this up, first one, there are a patient presenting to the ED with complaints of chest pain and shortness of breath following administration of the COVID-19 vaccine. After workup, the provider documents acute myocarditis reaction to COVID-19 vaccine. And the direction would be a code for the myocarditis, followed by a T code for the adverse effect, a T50.B95A for an adverse effect of other viral vaccines, initial encounter. The last one is our anaphylaxis patient presenting to the ED via ambulance, complaining of hives and swelling, severe breathing problems, and experiencing swelling in the throat following administration of the COVID-19 vaccine. So in this case, our provider is documenting an anaphylactic reaction. Two codes are needed there. The first one is the T8052XA, which is the anaphylactic reaction to the vaccine, initial encounter. We would list that first. Notice all these have the A on there for that last digit for initial encounter. We would also use that adverse effect, that a T50B95A as a secondary diagnosis for that patient. So that does conclude our COVID-19 content today. I'm going to turn this back over to Lisa, who's going to handle the Q&A and the wrap-up.
Perfect. Well, thank you so much. Because we are right at time, we are not going to be able to get to our any questions today, but if you did ask a question, we will follow up with you directly after. I am going to launch just a quick poll. Again, I know we are at time, but if you are able to answer, if you're interested in getting any more information about some of the 3M services that we do provide, you can complete the survey here. Complete the poll here. Once the webinar is complete, we would really appreciate, though, for you to complete the survey. We certainly understand and do appreciate that there was some technical issues today. We hope that it didn't take away from the presentation too much because the content was still spot on. So we really appreciate our speakers today with all of their valuable information. We will also be sending out an archive of this presentation as well as information to register for the next. That will be in September. And again, we certainly appreciate your time today. And again, please complete that survey at the end. We would really appreciate it. But other than that, again, thank you for your time today, and we look forward to hosting you again.